Welcome to The World Today, a program of Perry Worldhouse, the University of Pennsylvania's Global Affairs think tank, and the German Marshall Fund. I hope everyone is safe and healthy during these unprecedented times. I'm Mike Horowitz, Director of Perry Worldhouse and Professor of Political Science. Today's program is a virtual checkup on the war against coronavirus as a follow-up to our event with Zeke Emanuel and the German Marshall Fund in April. Once again, we are delighted to be partnering with the GMF on this and to be joined by its president, Karen Donfried. I'll now turn it over to Karen to introduce herself and the GMF, and then I will introduce Zeke. Karen?
Thanks so much, Mike. Delighted to be doing this again with Perry Worldhouse. I run the German Marshall Fund of the United States. And for those of you who aren't familiar with us, we believe that the US and Europe are stronger when they're working together. And I think that is certainly true at a time when we are both facing a pandemic. And I'm delighted that our networks on both sides of the Atlantic can benefit from the wisdom and experience of Dr. Emanuel again. So thanks so much, Mike.
Absolutely. We've got about 300 people logged in already, listening, and let me now introduce today's featured guest, who everybody's here to listen to, Zeke Emanuel. Dr. Zeke Emanuel is Vice Provost for Global Initiatives and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. From 2009 to 2011, he served as Special Advisor for Health Policy to the Director of the White House Office of Management and Budget. Since 1997, he was chair of the Department of Bioethics at the Clinical Center of the National Institutes of Health. He has both an MD and a PhD from Harvard, so he's a real slacker. He's a columnist for the New York Times. He's written or edited 9 books and over 200 scientific articles. He is the person we want to hear from to understand the coronavirus pandemic and what's going to happen next. Zeke, thank you for joining us today for our joint event with Perry Worldhouse and the German Marshall Fund. And the floor is yours to give us some introductory thoughts about how we're doing in the fight against COVID-19.
So thank you very much, both Karen and Michael. It's nice to be back. The first run through of this, as Karen reminded me, 6 weeks ago. Seems like forever ago or just yesterday, both at the same time.
It was 2 haircuts ago for me.
And we only one for me. It was a wonderful event, and I think the best questions I've had, frankly, on COVID. And so it was a pleasure to agree to do this again, and I hope we have a big international audience, especially from Europe, to get the European perspective and what's on their mind. Let me make, I think, 4 or 5 points here going forward. First, you see certainly in the United States, certainly in Europe, opening up of economies, as we now refer to it, and that is a steady expansion of the number of non-essential businesses, the expansion of the kinds of gatherings that can take place, and a look to get the economy rolling while still having effective public health measures in place. A lot of experience is going to be gained from that. The second point is one of the things we have seen in other countries that have been out, you might say, on the leading edge of this, such as South Korea, Singapore, is flares of people where there is spread and learning more about the spread. And so you see the episode certainly in Singapore, where they've had a very large expansion of the number of cases, putting them back several months, I would say. In South Korea, even, you've seen one person with COVID going to nightclubs and being able to seed, I guess last count I looked yesterday was about 161 infections traceable, not directly to that person, but that person to another person to another person. And you also see what good contact tracing can do, and how you can identify these people and really contain an outbreak if you have the right testing and contact tracing infrastructure in place. I think if I were to make so the third thing I want to say is we've learned a lot, or have thought a lot, about how we might reduce risks. So this is in the vein of practical advice that we've come to. We understand now that the various things that really increase the chance of contracting and transmitting coronavirus. So it's the amount of virus you see over the amount of time that you're exposed to someone. So if there's sort of breathing in the room, someone's exhaling 20, 30, 40, 50 virions, you know, you have to be present for a number of minutes, at least 20 to 50 minutes to sort of get one. On the other hand, someone sneezes or coughs, those produce a lot more virions in the atmosphere. It's much easier to get. Similarly, we have a lot of cases of transmission indoors, even in large areas like churches where choirs sing. You can easily get transmission because singing goes deep into the lung and then expels a lot of air. On the other hand, transmission outdoors is very minimal. And it's very hard if you're outside with someone to actually get it because of the wind, the dilution effect. So that leads me to the fourth point, which is if you look over the next 6 months, we probably are entering a good phase for trying opening up. It's getting warmer. Viruses, respiratory viruses are more cold weather. Warm weather tends to decrease the transmission with flu, with some coronaviruses. It's probably not going to decrease it as much as flu, but it will decrease it some. I think most people are agreeing some degree, 20%, 30% are being put into the models. Plus, we're going to add to that the fact that we're going to spend a lot more time out of doors. And again, that decreases transmission, which makes things like opening up restaurants with only outdoor seating a much more doable event and probably a much safer event. Doing a barbershop outdoors as opposed to indoors is probably a really good thing. So thinking creatively about how more activities can be done outdoors. I was just talking to the American Society of Media Photographers, people who do photographs. One of the things I recommended to them is get your clients, have your photographers get their clients to say, we're going to do outdoor shoots. We're not going to shoot in the studio as much as possible. So thinking like that, I think, is going to help a lot in terms of opening up. On the other hand, it also means, I think, that the fall is going to pose a lot of other kinds of risks. We're going to get more comfortable, engaging, going out to businesses, going out to restaurants. But in the fall, we're going to see, maybe a little complacency. We're going to see cold weather. We're going to see moving indoors. We're going to see the flu season, all of which combined make me very worried for the second wave, which is inevitable. I worry that because of this concatenation of events, things go up. So if I had to make one final recommendation to people, it is get your flu shot and make sure you get your flu shot early. And if you're over a certain age, get a pneumococcal vaccine along with that flu shot. The final thing I want to say is just talk a little bit about the vaccines. You can, if there's a positive effect of this, we have, call it 75 to 100 serious vaccine candidates. We probably have more brain power working on a vaccine for this than we've had on almost any other major biological initiative, maybe separate from decoding the Human Genome Project. Those are probably the two rivals. That's a good thing. And I think having competing plans with competing platforms. Last week, I want to say maybe a week ago, Barron's ran a reasonably good article, and I can get it to you, Mike, and put up on the website about where we stood with the various vaccine efforts. Suffice it to say, there are 4 different kinds of vaccines. There are 5, but let's talk about 4. The RNA DNA vaccines, that is, you inject RNA or DNA, the body picks it up, and then the body's own factory produces the antigen to prime the human immune system. Then there's sort of old style, crush up that virus, make it inactive or attenuate it, inject those particles into a person, have them make an immune response. Those tend to have some safety concerns, but we've made scores of vaccines that way. Third is take a vaccine that doesn't cause problems in humans, like chimp adenovirus, which is a cold virus, put in the DNA so that that virus, the adenovirus, expresses some coronavirus proteins to prime the immune system and inject that into people. The Oxford vaccine is like that. The J&J vaccine, Johnson & Johnson vaccine is like that. And the last is to take a artificial virus, a sort of lipid bilayer, a vesicle, and stick some proteins in that and inject this artificial, it's not really a virus, just an artificial vesicle with viral proteins into people and let the body react to that. The vaccine trials that have gotten off the start are the RNA DNA ones because they're easy to make, very low risk to people. So the Moderna and Pfizer, which are both in safety phase testing, and you saw on Monday that Moderna released results on 8 patients. Let me be cynical here. It's not the way scientists release data. So what was going on? Well, it was probably they were releasing it for Wall Street. They would need to raise more money to continue their work. You can sell more stock if you got positive results, and they got some results, and who knows how selective it was, how representative, but people want good news and globbed onto good news and sent the stock shooting up. But I wouldn't sell your fortune, mortgage your house, and buy that stock because 8 patients doth not prove. Remember, we're going to be injecting some set of vaccines into hundreds of millions and billions of people who are otherwise healthy. So it's got to be super safe, and it has to be effective at least probably for a year to make it worthwhile. So lots of room to go before that. The president's notion, which he announced a week ago, that we're going to have a vaccine before the end of the year. Certainly, if you mean a vaccine that the general public can get access to, that's definitely false. If you mean we might have a candidate that we might be able to produce and we might begin giving into frontline healthcare workers, for example, or frontline first responders, very unlikely, not impossible, but very unlikely. If I had to say, and this will be my final word of introduction, if there's a good lining to the Moderna announcement, it is, well, it does now seem very plausible. It's a proof of principle. People can develop antibodies in response to the spike protein and other things, which suggests we will be able to develop a vaccine to this virus. It still may be hard. It's definitely going to be hard. It still may be a long time, 12 to 18 months, and that constitutes warp speed in vaccine development. But I think we do have some positive indications that a vaccine is going to be possible. And so I think that may be the most optimistic element. That doesn't mean between now and when we can distribute a vaccine, it isn't going to be hard and it still isn't going to be painful. And again, my sense is that certainly the administration and many others are, I think, getting a little too exuberant about how easy it's going to be. And I really do worry about the shock of the fall. So with that, turn it over to questions. And
well, great. Well, let me start off with a question that asks you to, you're not just a global public health expert. You're a professor, and I want you to grade yourself. You've made a number of different assessments of the virus, since March, early April. What are the things that you think you got right? And is there anything that surprised you about the way things have gone, either in the United States or abroad?
So it's a little too early to tell whether my original, I think I was one of the first people out there saying, look, we're going to have multiple waves of this. Don't count on just one. Obviously, my assessment that we're going to have another wave in the fall, if not sooner, has yet to be proven. But I still think that's something that is important to the consciousness. So you asked for a grade. I am a professor. We do grade. We have to grade, and I am one of those people who loves to grade. I would say that
I hate grading.
I get somewhere between a B and a B plus. I don't know anyone who's gotten in the A- category here. Here are some places where I probably got it wrong. One, I initially drank the CDC Kool-Aid about masks, totally wrong. I flipped. Ahead of the CDC, I flipped, and I think early April, maybe late March, I publicly said on TV,
Right.
we should all be wearing masks. And either today or tomorrow, we'll have an op-ed in the New York Times about wearing masks and how we can increase the number. You know, in Hong Kong, it's 99%. In the United States, it's somewhere between a third and 2/3. We need to push that number up, and we need to keep wearing masks for a long time to come. I should have never believed the CDC, and now I know to be skeptical of almost everything they say. But I do think that that was a mistake. It was a mistake of our system to say we've got to protect the N95 and not to think more creatively how we can get masks out there, how we can produce masks for the public, make a big difference. And I think that's something which we really need to do. This issue of indoor, outdoors, number of viruses, concentration of virus by time, I think is something that everyone's it's been slow to pick up, and how the transmission happens. I think we had to learn a little bit more of, and not encouraging people to be more outdoors. I was an early advocate. Certainly, I'm here in Washington, D.C. I tried to urge the city to close down lots of streets as well as Rock Creek Park permanently so that people could have place to exercise. I was against closing state parks. I do think outdoors is really important, and I thought it was mainly for mental health, but also because it's good for mental health, physical exercise, and low transmission. Become even more, you might say, an advocate of it. I think, you know, one of the big, I was probably wrong on the Georgia opening and the Florida opening leading to spikes. The jury's still out. But what we can say, it hasn't had a huge increase in just 2 or 3 weeks. We will see 6 to 10, where I am a little worried. Unfortunately, we've just had reports early this week on both Florida and Georgia playing monkeys or playing games with their data. So I don't know how much we're going to be able to trust. And that makes me nervous. But we'll, you know, unfortunately, mortality is something you can't fudge, really. You can fudge the causes, but the excess mortality is something we'll be able to see. But, you know, I'm not 100% convinced we're not going to have, because of the types of businesses that they've opened, we're not going to have a real bump up in transmission and therefore hospitalization, et cetera.
Karen, you want to jump in?
So, Dr. Emanuel, that was a terrific overview of where we are. And I'd love to draw you out specifically on the issue of reopening our societies and our economies, because that seems to be very much the topic of the day here in the United States. One of the key criteria in this issue of seeing declining cases for more than 14 days seems that for much of the US, we are seeing those declining numbers of new cases, except it's not true here in Washington, D.C., where the two of us are sitting. It's not true in Chicago. It's not true in LA. But otherwise, we see that trend. And last week, I had a conversation with the head of Denmark's health authority. And most of Europe is ahead of us in terms of reopening. And he made 2 points that I'd love to have you react to. He said the key for them in reopening was first the need to, in his words, control your epidemic. And what he meant by that was relying on the power of data. And you were just saying in response to Mike that, well, I'm not so sure all of our data is reliable. So that's one issue. And then the second issue is, in his words, looking for long-term sustainable solutions. And that gets to testing, contact tracing, having focused isolation of those new cases. And one of our listeners has already asked about privacy concerns with regard to contact tracing. So what are the parts of this model that you think fit the US context well? And where are the places where the United States is going to struggle to meet those standards?
Great question, and I should say questions. There are about 3 or 4 buried in there, but they get to the heart of a lot of issues. So the first thing is the best places to, that have looked at opening up, I think, are focused on several things. First, let's not rush to the end. Do it in phases. Let's start with businesses And I think Connecticut, which I've been advising, has a very nice matrix where on the x-axis, they look at the economic impact. You know, how much economics do they add, and how many people, employment. And on the y-axis, they look at public health risk and how hard is it to open up, how easy is it to do outside, how, you know, what's the clientele, is it older or younger? And, you know, you want to concentrate in the bottom right quarter where low public health risk, high economic impact initially, and also, as I mentioned, those places that you can move outside, like restaurants out of doors, I think is probably a better place than beginning with restaurants indoors, just as a crude example, or coffee shops where there's outdoor seating and no indoor, not do indoor seating. Outdoor farmers markets as opposed to, you know, grocery stores. So I think there's a whole series of things that we can do in terms of opening where we can do it more safely. I've been a big advocate, and we're going to have an article coming out in the Atlantic about opening summer camps for kids because kids are a low risk group. And summer camps are probably very important for a lot of their development, socialization, learning, nutrition, exercise. Now, they pose, if kids get it, they do pose risks to their parents, etc. And we've got to take that into account. But I do think opening for the children is probably a really good idea. And Denmark, as you know, and Germany have done that. And I think, you know, learned a lot. Denmark, it had a slight uptick in the transmission, but didn't go over 1. And the R0 didn't go over 1, and it's come down, and I don't think it's raised serious concerns. Similarly, you want to, I think, when you reopen, make sure you take extra precautions in protecting the most vulnerable people. Obviously, the elderly, but serious protections needed for people who have comorbid conditions, whether it's obesity or diabetes or hypertension or smoking, because those people are at much higher risk. And I do think we need to recognize that we need to concentrate on them. I think Germany, for example, has done a very good job of that, better probably than almost any European or the United States or Canada. And you can see that in their statistics. So I think that's what one of the things we need to do. Look, as we're getting to the fall, we do need to rapidly increase our testing. I think we're finally getting our arms around it. Development of antigen testing, development of high throughput PCR. Hopefully over the summer, these will all come to fruition, and we'll be able to do millions of tests a day, and people who really want it will be able to get it. So I think that is important. We do need to sort out this issue with better contact tracing and hiring hundreds of thousands of people. The estimate is between 1 to 300,000 that we need across the country for contact tracing. And I don't think, as South Korea has suggested, well, you need to employ 36 million people who are recently unemployed. It's not a bad idea. The other thing I would say is going to the last part you had, privacy concerns. So I work for the Center for American Progress in my copious free time. We issued a report about a month ago about the issue of using tech for contact tracing and privacy. And what we recommended is, look, let's have a trusted organization. That's not the government, because many people are suspicious of the government having data, and it's not big tech, with many people are equally suspicious of them, but it's an independent, trusted group that does get our location data, does not combine it with other databases that we don't want them to, does not commercialize it, and does destroy, doesn't keep a shadow copy, destroys those data after 45 days when they're no longer useful for contact tracing, and let them begin to use this data for rapid contact tracing and augment the 1 to 300,000 physical contact tracers. I think that is something the American public would like. I think it was Ezra Klein who had the very nice quip, you know, I love my privacy, but I love my mom more. I do think there's an element of that. And we've already seen lots of sort of cultural, behavioral and changes in habits. And I think this is one of the areas where COVID is forcing us to change our habits. We don't shake anymore, right? We wear masks. maybe we're willing to give up some privacy, not so that Facebook can make more money or Google can make more money, but so that more people can be protected. That, I think, is the key difference. What's the reason we're going to give this privacy up? And can we be sure that that data is not being commercialized and is going to be destroyed? I think those are the safeguards that would make us more comfortable. The problem in the United States is, unlike the Scandinavian countries, for example, where they give the government data, the government's very good about protecting their privacy and yet using it for public health measures. We don't have that combination, that trust in the government to do that, and it's unfortunate, and we can see the cost of it.
So I think my mom is actually in here, and so let me just say I definitely agree that I care about my mom more than I care about privacy. But
now you're the favorite son, Michael.
We have a lot of questions that have come in, and one early one goes back to something you mentioned at the very beginning, the sort of lack of trust you have in the proclamations of the CDC at this point. As an American, I was trained to think it as a graduate of college in Atlanta. I've been trained to think of the CDC as the sort of be all end all of American healthcare and in some ways global healthcare when it comes to these kinds of situations. Can you maybe tell us a little bit more about why you're skeptical of the CDC and maybe what we could do to address that?
Well, I'm less skeptical of the CDC and I'm more skeptical of the political pressure and the cumulative undermining of the CDC. I was, maybe you mentioned, I was at the NIH for 14 years, 97 to 2011. And we worked close, and when I was in the administration for 2 years, we worked closely with the CDC. I have the utmost respect. They have developed lots of world-class training in epidemiology, in infectious disease identification, just outstanding, as you point out, world-class. But we have seen a kind of politicization and frankly, also some of their own missteps on the testing side of things. But they had detailed guidance for, schools, for restaurants, for others, but that was quashed by the White House as too detailed, too prescriptive, too federal, as it were. And that's a mistake. Again, I can't tell you the number of inbound calls I am getting from people. There's no CDC guidance. What can you advise us to do about X, Y, and Z? And I think that is a big problem because now you're forcing individual groups or restaurants to develop the guidance on how to open safely rather than having, all right, this is the minimum floor from the CDC, and then you can add on or you can make other suggestions. But you have a authoritative template. It is a sad day when our government, gives up responsibility for doing that precisely when the government has the skills, has the talent, and it's squashed. So that's, I think, my worry. The other thing I would say is we have had, I don't know if a war on expertise, but we have had a undermining of the value of expertise. This goes along with periods of populism, as you know better than I, both of you know better than I. But we do have this sort of attack on the value of expertise, which is in stark contrast to where we were coming out of World War II in the 50s and 60s, where expertise, especially scientific expertise, was viewed as valuable, and it's not just valuable, but actually essential to national advancement. Now we're at just the opposite stage. And one of the consequences is that when that becomes the philosophy of the government, you run a lot of the scientists, either they shut up or they stop or they leave government service. And we've unfortunately had a lot of that. And that is a very bad place to be because when you need the expertise, you don't have it. And it's hard to get those people to trust that, oh, returning to government is going to be a safe career path. I'd be able to actually have a big impact, which is typically what motivates people to go into government service. And it's a loss. Early on in this, I think President Trump was confronted by the fact that he had recommended a 19% cut in the CDC budget and had encouraged scientists to leave by his policies and pronouncements. And he says, oh, we know where those scientists are. We can call them back anytime. That is utter nonsense. You know, they get, most of these scientists, especially the epidemiologists and others, there's high demand for them. They get good paying jobs outside. The reason they stay at places like the CDC is, again, because they can have global impact that is huge. And if you discredit them, if you undermine them, if you prevent them from doing their job, they leave. And you can't call them back on the dime. And that's just a wrong-headed notion. Hopefully, one of the things COVID has done is convince the public that having good scientists in the government, having a government you can trust, having a government that is competent does make a difference. And that the populism that the government is the enemy that we've been having, certainly since Reagan, if not before, is a bad, not a good thing to do. It undermines our ability to confront not just crises like COVID, but everyday activities.
Karen?
So one of our callers is interested in hearing your perspective on the Swedish model. And I'd like to expand on that question a little bit, because I had the opportunity to speak with Sweden's chief epidemiologist, Dr. Anders Tegnell.
Yeah.
And Sweden in many ways is the outlier here, because essentially Dr. Tegnell believes something you said earlier, which is the key is to protect the vulnerable. So they did that in Sweden and didn't put in place a general lockdown. The rest of society continued as normal. Now, this has been controversial, and the death rate in Sweden has been relatively high. There are about 3,000 Swedes who've died as compared to 500 Danes, for example. But I want to connect the Swedish model to the comment you made about a second wave. Because the argument that Dr. Tegnell is making now is, hey, look, our strategy is smart because about 40% of the folks who live in Stockholm are essentially going to be immune to COVID-19 by the end of this month. And that will give Sweden an advantage in living with a virus that will be here, in his words, for a very long time. So he, like you, anticipates a second wave in the fall. Sweden will have this higher level of immunity, and the number of cases in Sweden, he postulates, will be quite low. So what is your take on the Swedish model generally, and do you agree with Dr. Tegnell's assessment of the implications of that strategy for a second wave?
Great question. I think it was Aristotle says you don't judge the quality of a life until the very end. And we will, you know, the ultimate question is how many people die, how much hospitalization occurs, and how much economic damage happens. We can't fully judge that until we get through everything. On the other hand, we have to make decisions prospectively, and we can't wait to the end. So I'm a little skeptical of his perspective in the following way. So what Sweden did is, and they have been pretty vociferous in saying, look, we didn't go the other way. We didn't just let it run through society. We did say, advise people to distance and adopt public health measures, but we didn't create legislative or legal shelter-in-place orders and other close of non-essential businesses, close restaurants, close bars, because of the high level of trust and that people would follow government advice, but we didn't need to back it up with the shelter-in-place orders. And the consequence is that more normal economic activity could occur. So here's, 4 or 5 levels of skepticism about that. First of all, the data are pretty clear that yes, the public, not just in Sweden, but everywhere, changed their behavior before the formal shelter-in-place orders were issued, that the people were afraid for their own health and therefore changed their behavior to adopt quasi-quarantine measures before official arguments. But it is the case that in Sweden, it was fewer people and they restricted their activities less than in neighboring countries like Denmark, Norway, and Finland. The data are pretty clear that everyone's had a dip in, say, business activity or going out, but the Swedes were less. There is a added value to the public announcement to tell people what the norm is. And so I do think that helps. Second of all, other measures like wearing face masks are not very common in Sweden. They haven't done a great job about protecting the elderly. Third, as you point out, their death rate is higher than neighbors. So it's much higher than Germany, Denmark, Finland, Norway, Austria, Switzerland, I believe. It is lower than France, Italy, which have different items. Sweden also does have an advantage. Over 50%, I was shocked to learn this, over 50% of the Swedes actually live alone in their own apartment. So you don't have what Italy, yeah, exactly, 56%. What Italy, the problem in Italy was multi-generational households, close living quarters. That Sweden doesn't have that problem. It's also a country of low density. It's a country of low obesity, generally lower chronic illness. So it had certain advantages going in. Will the high, maybe immune rate that is being anticipated in a city like Stockholm, is that going to protect them in wave 2? 40% is not sufficient for herd immunity. It may be sufficient to keep the R0 low. But that we're only going to find out when we find out in the fall. And I'm a little skeptical that the Swedes are going to get that big a boost. Put all that in a package. They're also anticipating 7 to 10% decrease in the GDP this year. So it's not like they've escaped the economic pain so they have a lot of public health pain in terms of high numbers of deaths, and they're also going to have a big economic pain. So I'm not sure that's the great model. Now, his point is this is a marathon. It's not a 1,500-meter dash, and therefore judging us in May may be the wrong time period. You may have to judge us in May 2021, and we may turn out to be better than our neighbors because of this added immunity, the trusting of people, etc. I'm a little skeptical that he's going to have that much of an advantage come the fall. I don't think it's necessarily if I were going to go their route, let's put it this way, I probably would have done it differently. I would have had a much more vigorous public health campaign, much more vigorous norming, much more vigorous use of face masks, and a few other things.
So I want to take us from the very global in some ways to the very local, which is that I think there are 3 or 4 different questions in the Q&A about something that a lot of parents, both in the United States and around the world, are wondering about, and that is summer camp. And whether there's any possibility for summer camp. Everybody wants to get their kids out of the house right now. Is there any possibility for summer camps or ways to do that safely? Do you have any thoughts on what you think might happen and how to make that safe if any camps do open?
So as I mentioned, we have an article coming out in the Atlantic, hopefully in the next few days, where we do advocate for opening summer camps.
Okay.
On my MSNBC show on Friday, I did advocate for opening summer camps. Right. So I'm an advocate. So here's my rationale. First of all, we have disrupted kids' lives pretty badly. Literally overnight, we took them out of school. We've said, you're confined to home. You can't see your friends, and you got to learn from a screen. All pretty terrible impacts. Bad on learning, especially for younger kids. The younger your kids you are, the harder it is to learn from a screen. Bad on socialization, which we know has long-term positive impacts on kids, both mentally, but also socially and even physically in terms of their actual health performance. I do think summer camps are a good thing, especially summer day camps, and we could talk about overnight camps because I do think there's a way of running longer overnight camps safely. But look, why should we open up day camps? From a child development standpoint, very, very important. And I think that's pretty uncontroversial. So then the real question is, can we do it safely? Okay, safely depends upon what's the risk to children. Risk to children is relatively low. Again, if you look at the number of cases among kids versus the number of cases among adults in the United States, overall, there's been 420 cases per 100,000 people. Among kids, it's about 58 cases per 100,000 kids, so a much lower rate. So if kids are getting it at the same rate as adults, they're not manifesting it, and not as many serious problems. Second, we do have this multi-system inflammatory syndrome, but I think, as I mentioned, less than 200 cases in the whole country. So yes, it's serious, but not that serious.
Somebody else in the Q&A asked about that in particular.
Second, the number of deaths of kids, we don't actually, ironically, have a great database on it, and the CDC data are behind others, but it looks like there's less than 200 deaths in kids under 25 across the country. And collectively, the risk for kids are low. And then if you run summer camps, remember, most of the counselors are also kids. They're 16, 17, 18, 19, also at relatively low risk. Finally, I think you need to put their risk from opening up summer camps in the context of the risk they face in everyday life. You know, life is, I always like to say, life is not risk-free. We have lots of risks. Driving in a car in normal times, bad risk for kids. Unintentional injuries, about 12,000 deaths a year from unintentional injuries, swimming, bathing, other things for kids, gunshots. We also have child abuse, which we know is probably going up because we're confined to the home. 5 deaths a day in the United States from child abuse. So having camp, I think, is going to be a good thing. You can also reduce the risk of camp, having kids wear masks, having kids stay in pods, doing as many activities as possible outside or in very, very well ventilated areas. Again, the Danes have taught us a lot about how to do this safely. So the big risk is to adults, 3 groups in particular. The college, the camp administrators, the people who are over 30 who are running camps. Yes, they face some risk, but I think a lot of them want to get open. Not all of them. I've talked to some who don't, but a lot want to be open and are willing to take that risk. Parents, especially parents who might have comorbidities, there is a risk, and they shouldn't, probably shouldn't send their kids to camp, or if they do, understand the risk. And then multi-generational households, like in Italy, we know that grandparents can be affected. So I do think that there's a balancing act, but I think on net, summer camp is important. Remember, and this is what primed me, I have a colleague who said, at least my kids now are doing homework, taking classes online. It may not be optimal, I'm having to serve as a teacher's aide, but it's a structured time. Now you're going to go into summer, no structured time, no friends, just sitting around the house with nothing to do or being able to go out in the same small area. That's a terrible formula for children. So I personally am a big, big advocate of summer camp, knowing that there are risks, knowing life is not risk-free, but thinking it's well worth the gamble, and thinking that as we get experience, we will be able to learn to mitigate the risk. Will some kids get COVID-19 as a result of opening summer camps? Inevitably, but we shouldn't use some risk of kids getting COVID-19 as a way of not to do it. We need to compare it to the other situation. Now, I know that my position, I think, is in contrast with Tony Fauci's, who I think has been, a little more protective of kids and suggesting that rushing to open schools, etc. So, again, we're not going to know, but I do think the balance of socialization, learning, physical activity, friends, is really important.
You're capturing so well this tension between people wanting to return to some semblance of their normal life with the risk that's there. And, as we were talking about, okay, you need to control the epidemic, you need to have long-term sustainable solutions. Some of the questions in the queue are playing off of 2, let's call them wild cards. One of them is, how do you manage asymptomatic carriers in this? And do we understand anything more about asymptomatic carriers, A? And B, in trying to control the environment, how does international travel fit in? Because if you're trying to prevent a second wave, you're trying to break those infection chains. If you're importing the virus from someplace else, how do you manage that? So could you speak to asymptomatic carriers and international travel? Thanks.
Yes, so asymptomatic carriers, we definitely know that they're important. I think there's appreciation that they're more important than we thought early on. I think some of the early data suggested they weren't important, but a number I've seen is that about 44% of transmission is from asymptomatic carriers. That means people who don't have symptoms and yet have the virus, or people who transmit it before they have symptoms. In the end, they're not asymptomatic, but they're pre-symptomatic. So I think those are the two categories. And we are seeing that that is a lot of transmission. And we need to be much more aware of that, which is why the general requirements of we need to protect, wear masks, physical distance, even if most of the people aren't going to have it, some people might, and they might not know it. And that's a way that contagion can happen. And it's also a reason to stay outdoors and minimize going into places. We do need to test. First of all, we need to know what the seroprevalence is. How common is the virus in a community? That's very, very important for understanding the interactions and learning who's going to be affected. We don't know what tips people into being, people who look the same. Some are asymptomatic, some are symptomatic. Is it genetic? Is it the amount of virus they initially got? We just don't know enough yet to be able to say, oh, you're going to be fine. You're likely to be asymptomatic or minimally symptomatic, and you're not. And age is only a moderate proxy. We have a friend who got it, and 31 years old, otherwise great physical shape. 10 days, fevers, shortness of breath, and then the long-term consequences. Again, we don't know, but we do know that some people do have long-term respiratory and other consequences. I think last week, maybe last Wednesday or Thursday, there was an outstanding article by a New York Times reporter, 33-year-old woman, lived on the 5th floor, walk up, easily did the walk up, and then suddenly, literally overnight, in a hospital, respiratory distress, and now, even after out of the hospital, recovered, still persistent respiratory symptoms. So I do think, we can't be cavalier about the impact, and we don't know why some people get it worse than others. This is going to be one of those big mysteries that we're going to have to try to solve with a lot of testing, not just who gets it, but what else is going on, what's their immunotype, what's their genotype in other areas that, like the ACE2 inhibitor that seems to be critical for getting it. So that's just going to take us probably a long time to sort through.
So Zeke, following up, in some ways on both of these, the single question in the Q&A that the most, we've got the most variance of is about reopening schools in the fall. Both, universities, high schools, elementary schools. I think we've got 10 or 15 variants on those in the chat. And so, could you tell us how you're feeling about that? You just made all the parents of America and the world really happy with your summer camp answer. Do you have similarly good news for us for schools? How should we be thinking about that, especially given the possibility of a second wave?
Well, exactly. So here's the bad news for the fall. The bad news for the fall is cold, right?
Right.
And therefore having to move inside, the virus probably being more easily transmitted in the cold, et cetera, et cetera. So that's the bad news. Now, if you're an optimist and you want the good news, I was on a call yesterday with Scott Gottlieb, former FDA commissioner under Trump, a man I respect a lot, very thoughtful, on the board of Pfizer, so has a lot of data from the pharmaceutical side. And he says, look, that's true, but one of the big differences between today and the fall is we'll probably have a bunch of therapeutics that will be available. We have remdesivir, modest at best. He says there are a bunch of antibodies, maybe convalescent serum will be shown to be effective and we'll be able to collect a lot of it and have it for patients. Maybe we'll learn about an intervention that can prevent binding to the ACE2 inhibitors without causing additional other problems. Maybe we'll figure out how to prevent some of the clotting. Anyway, so the optimist says, you know, over the next 4 months, we'll learn more in the fall and the risks will be different. I do think that the Danish example gives me courage, but there are lots of things that come with the Danish example. One of the things they've done, which I think is going to be hard to do in the US, but maybe worth it, is they set up auxiliary classrooms in tents outside schools. Well, we have, you know, we can have mobile classrooms, and they've cut classrooms in half. So you get more teachers, teacher aides, and you have fewer students. Now, they also think, if I'm not mistaken, and maybe Karen, you know more about this than I do, they think there's actually been a big advantage in the learning as a result of cutting classes in half. And one of the things apparently I understand the teachers union in Denmark is doing is trying to negotiate with the government and said, listen, we like this half classroom thing. Maybe we can make it permanent. It's better for education, at least for a while. It'll be better for the public health side of things. But I think those are the kinds of things, if we want to reopen schools, we need to do. But we understand that in the United States, we're going to be running headlong into state governments that are going to be facing huge revenue shortfalls.
Right.
And unless the federal government comes to their rescue, specifically with, it's really important to open schools. Here are the kind of things you need to do to open schools. And we're going to support you with money to open schools, hire more teachers, put up mobile classrooms or other areas that can be more open, more ventilation. You know, maybe you'll have to do teaching in the cold, but, you know, to have wind literally going through the classroom. Anyway, I think those are the kinds of creative ways we need to think about it. But one of the points we make in this article about summer camp, one of the reasons, one of the other advantages of opening up, it's hard to open up your economy and get parents fully working and productive. You know, they can log hours, but if they're also listening to the kids, if they're playing teacher's aides and interrupting, this is how you do multiplication of fractions. It's hard to actually get even, you know, good people who are committed to working at full tilt if they're constantly distracted and having to play parent, worker, spouse, maybe caregiver. So I do think opening up schools is going to be important. And again, it's not going to be risk-free. And there are some kids who do themselves have comorbid conditions or have parents or grandparents who have comorbid conditions. So if you're asking me, one of the things I would say is, now we've got this fancy phrase that everyone's using, the hybrid model. The question is, what's your base model? Is your base model in-person teaching, or is your base model going to be online teaching? I do think certainly for lower grade primary school and probably through high school, the base model has to be in-person teaching. There, you know, older teachers and staff of schools are probably the people at the biggest risk. And I think we're going to have to figure out how to work with them about it. But again, one of the things I think, you know, in my optimistic daydreams is this might be a great opportunity for a lot of kids who've just graduated college. Let's suspend the teacher requirements and say, all right, we're going to hire a bunch of them to become teachers, and maybe we can get them into the profession long-term because they actually enjoy what they're doing, and they can really find purpose in that. I think all of that would be really important to do.
Karen?
So I'd love to zoom out now on the pandemic, because you wrote a really thoughtful analysis of why many highly infectious diseases appear to start in China. And that was echoing in my head this week, because of course we've seen the annual meeting of the World Health Organization taking place virtually. And that World Health Assembly has been overshadowed by President Trump's threatening to permanently stop US funding for the WHO, reconsidering US membership until major improvements have been made. And he in particular has been criticizing the China-centric coronavirus response of the WHO. And from where you sit, should we as Americans or Europeans, can we solve this pandemic nationally? Do we need to cooperate through an organization like the World Health Organization? Do we need to be working with China on this? Just to help us understand that dimension of the pandemic.
Well, first of all, full disclosure, I'm a special advisor to the Director General of the WHO. I am a big believer in the WHO. 6 a.m. I was on a call. We have an ethics working group at the WHO, and I was on that call helping to, among other things, draft guidance out of the WHO. So I'm a big believer in the WHO. Look, we need some international organization that's going to coordinate health responses to public health emergencies, but also national, helping with developing national infrastructure, international guidelines for lots and lots of things. So there's no other organization. The WHO has to do it. We can't do without it. And this is a silly, we're going to withdraw. That's not the answer. And it's not even a good approach. And there are plenty of Americans in the WHO, probably more than any other country, actually, Donald Trump. They've hired a lot and are in senior positions of leadership. So I think this sort of hostility, goes along with the sort of nationalism, but that's not the right response for the moment. I think your question is absolutely right. You want to solve a global pandemic, there's no way, unless you're, say, New Zealand, of sealing yourself off. And then if you're New Zealand and you seal yourself off, your economy goes kaput, and so much of their economy is dependent upon global trade. So if we're going to, I think you asked before, but I probably didn't answer, international flights, international relations. If we're going to have international relations, we have to have an international response. And so you can't just say, well, we can solve it in the United States. As your question correctly implies, this is a global problem. It's going to require a global solution. Even if we find a vaccine, it can't be, well, only the US is going to be safe, because you're going to want international travel. We're going to want other people coming here, and you're going to need to have a situation where we've limited the spread in other places. It is probably the case that we're never going to eliminate coronavirus, SARS-CoV-2 from the world, but we can minimize its impact. And I think that's what we have to look towards, and that is going to require both global collaboration and effective response. I don't think the WHO has been overly favorable to China. I do think that they've recognized some ways in which the Chinese have been cooperative. I mean, they did release the genome. Maybe they didn't release it fast enough. Maybe they didn't tell the world. They were trying to suppress it internally just as much as externally early on. But the fact is that they have not been coddling. And the issues certainly that we have been confronting, I've been confronting, but in my participation with them, are issues that every country deals with. Immunity passports, so-called, how to allocate scarce resources in a country, how to allocate resources across countries. These are issues for everyone, by the way, not just poor countries or developing countries or only rich countries, and making sure that the entire world is attended to, because this is a pandemic. It's a worldwide problem.
So Zeke, we're almost out of time. I want to ask one last question that's also appeared in several variants in the Q&A, and that is about information and misinformation. And I think the way I'd like to sort of combine those is saying, public information and figuring out best practices is so important. From your perspective, as all of us try to navigate our, individual, in some ways, risk tolerance and what we're willing to do and, what we're not willing to do, what are the kinds of information sources we should be looking for, and, how can we combat misinformation in trying to figure out how to emerge from lockdown in the United States and elsewhere, and, and knowing when we might need to go back into it if a second wave occurs?
Yeah, I think it's the latter that it gets me a little nervous. If you've got people manipulating the data, trying to decrease the number of cases so that they don't look so bad, that does get me nervous, because then you'll miss an outbreak because you're playing games. If we manipulate the data, we're going to make mistakes and we're going to put people's lives at risk. We've already seen how suppressing data or suppressing information or suppressing knowledge of outbreaks has impacted the United States. It's probably caused tens of thousands of extra deaths here by that measure. I also think it'll prevent us from knowing what's working and what's not working, and to pivot away from what's not working to what's working if we don't have good data. So it's absolutely essential. You know, there are there are better independent websites that you might look at. You know, I tend to look at the Hopkins a website for the total numbers. I like the New York Times for the state-by-state breakdown. I think it's also important not to look at any one epidemiological model, but to look at multiple epidemiological models to see what the apparent consensus is. There are very different assumptions there and very different groups out there. Remember that confirmed cases, there's a small part of the iceberg, there's a bigger part underneath. Remember that hospitalizations is a lagging indicator and deaths is an even more lagging indicator. It doesn't tell you what's happening right today, it tells you what's happened weeks ago in terms of spread. So I think we have to do a lot. It doesn't help that the administration, you know, the president himself is pumping hydroxychloroquine, is pumping not wearing a mask by his role model. They don't social distance when they get on stage or at meetings. I have a colleague who was watching the Space Council meeting. No one was wearing a mask and they weren't social distancing in a meeting, and it was indoors inside a conference room. This is no way to role model, and we need role modeling because that's the way we communicate norms to people who aren't following this on a day-to-day basis. And so we need better behavior by our leaders in this.
So while I wish we could talk to you all morning, frankly, about this, we're out of time. Dr. Zeke Emanuel, thank you so much for joining us on The World Today. And let me turn to my partner in crime, Karen Donfried of the German Marshall Fund, to close us out.
Well, an enormous thank you to our audience. We're so grateful you all tuned in. You sent us phenomenal questions, and Mike and I tried to do those justice. And Mike, wonderful to cooperate with Perry Worldhouse. Look forward to future events as well. And Dr. Emanuel, thank you for making all of us smarter. So wishing everyone
Thank you both for having me
rest
on.
of their day.
It's always a pleasure. And as I say, the best questions are during this time period. So thanks.
Thanks a lot, everybody. Have a good day.
Bye-bye.
Stay safe.